Hello, everyone, and welcome to the latest edition of the Vitality Coaches Wellbeing Programme. And today we're doing it in partnership with Check4Cancer. My name is Jamie, and I'm part of the coaching team at Vitality, where my role is Head of Health Engagement. And the subject for our event today is one which will affect 1 in 2 people during their lifetime. And at Vitality, I think that looking after people is like the core of our organisation. The conversations that we are having around the topic of cancer are really sensitive. So I think it's important to say that wherever you are right now and wherever you're joining and listening from, please do exercise some care. And I think that, whatever you're hearing today, if it's worrying you or concerning you, then the message that we need to make clear from the start is so simple that if you have any concerns, any questions, or any doubts, please do seek medical support, and there'll be the right people in places to help you. So that's the most important message for us today, immediately. But we are so fortunate to have Professor Gordon Wishart sharing his knowledge with us once again. Gordon is the founder, the CEO, the CMO of Check4Cancer, who are a leading early cancer detection and cancer prevention organisation. Now, there are, I think I'm right in saying, more than 55,000 new cases of breast cancer and 3,200 cases of cervical cancer diagnosed in the UK each year. And Cancer Research UK has suggested that 23% of breast cancers and 99.8% of cervical cancer cases would be preventable if appropriate screening procedures were implemented and adhered to. And that's why at Vitality it's so important that we have the partnership with Check4Cancer, and we do make that available to our members. So if you are a Vitality member, please do make sure that you check out the offering there if you need it. And if you're not a member, there's still ways that you can access that as well, and we'll come through that as well. So during this session, we're going to be providing information about the signs and symptoms of breast and cervical cancer, hopefully helping people understand their own personal risks. And we're also going to kind of encourage the use of screening and diagnostic pathways where it's applicable. We're also incredibly grateful to be joined by a Vitality member who is Lisa, and she's been through the cancer treatment, and she is so kindly going to be sharing her experiences, learnings, and providing hopefully some valuable insight. And we think it's so powerful to hear from someone that's been through something so potentially life-changing, and we're really grateful that she's going to share that with us. So the final part of the session we'll then come to is a dedicated Q&A, answering as many of your questions as we possibly can. So I'm going to make sure that we get as much out of this session as possible. So at this point, I'll introduce Gordon. So good to see you again. How are you?
Yeah, thanks, Jamie. Yeah, good to be here and good to be, tackling this subject again and trying to raise cancer awareness.
Yeah, for sure. I think it's one of those things that we always talk about during the month of October. Our theme for October is women's health in general. There's a breast cancer awareness month associated with October, but it doesn't just happen in October. So I always think these are the most important sessions that we ever do. So Gordon, yeah, thanks so much for your expertise and knowledge. And we're actually going to get straight into it today. And what we're going to do is we're going to start off with breast cancer. We're going to go all through the different information that's relevant there, and then we'll move on to cervical cancer, and then we'll bring Lisa out for a chat as well. So Gordon, first things first, and forgive like the direct approach to this one, but I think we need to just get straight into it. Breast cancer, initial signs and symptoms that people should be looking out for where they could potentially maybe need a little bit more support.
Yes, so yeah, we can run through these now. So I suppose the one everybody's aware of is if they find a lump, and obviously if it's a new lump that they've never felt before, and they can't find something similar in the same place in the other breast, then that's something that should be investigated. The majority of lumps that are investigated in a breast clinic do not turn out to be breast cancer, but women will need further investigations to make sure that they are being reassured correctly. Now, some of the other symptoms are a bit more subtle, and that might just be a change in the shape or the contour of your breast, or you might notice a dent in the skin of your breast, especially when you put your arms in the air. And that's why we ask people to look at themselves in the mirror, both with their arms by their side and their arms in the air, because sometimes those subtle changes in the shape are only seen when you put your arms in the air. Another symptom is getting bleeding from the nipple. That always worries women because it's such an unusual thing to happen. But in fact, although it needs investigated, somewhere in the region of less than 5% will actually turn out to have an underlying breast cancer that's causing that. Apart from that, breast pain is very rarely a cause of breast cancer. It's usually a sign that there's perhaps a larger or more advanced cancer that's causing pressure in the breast, and that's why it's causing pain. But most causes of breast pain are absolutely fine. They're part of the normal menstrual cycle, and nothing to worry about. So it's really a new lump, change in shape, change in contour, bleeding from the nipple, and those would be the main ones we would ask people to go and get checked if they find that these symptoms are new and are worrying them.
Perfect, thank you. And I think one of the key questions that we had before was about pain, so you've addressed that point really well. But again, like, I can't say this enough today, if you are concerned or unsure, just make sure you get it checked out. Gordon, then moving on to the kind of like screening and diagnosis process, would you be able to talk us through that? And another common question that we've had a lot of people ask about is like age ranges and kind of like when the right times to be checked are.
Yes. So the NHS breast screening programme was one of the first screening programmes to be introduced in the UK. And it now screens over 2 million people a year. So for most people, the breast screening programme will start at age 50, and women will be invited to attend every 3 years until age 70. Beyond age 70, you won't get a regular invitation, but you can refer yourself for a mammogram every 3 years after the age of 70. So for those women aged 50 to 70, the uptake is on average just under 70%. So about 70% will accept the invitation. Now, if because of your family history, you're at higher risk, then you may start screening earlier. There's a group called moderate risk, where you have, a fairly significant family history. And for those women, they can have screening from age 40 to 50, and that would be done every year. And the reason it's done every year for that age group is the breast tissue is very dense. So the x-rays don't get through the breast easily. And so you get a much less clear picture. So you have to do the test more often to try to not miss out on any cancer. Those people at the very highest end of the risk, and that's usually because they've inherited a breast cancer gene like BRCA or one of the other genes, they get regular mammograms and MRI scans from about their mid-30s. But that would usually be done in the context of a specialist clinic in the hospital. Okay. So it's kind of tailored to risk.
Yeah, amazing. And on that note, will people be reached out to when when you mentioned if you hit 50, are you expected to know that yourself, or do you get an email or a letter or something to explain?
You should get a letter inviting you. It may not happen on your birthday when you're 50, but it'll happen sometime in the next 18 months usually. So yes, you don't have to do anything. It should all happen automatically through your GP registration.
Perfect. Amazing. Thank you. And then I guess what we're going to come on to now, which is if the unfortunate situation is that you've gone through the screening process, you've then been diagnosed with some form of breast cancer. I know this is going to be completely different and individual, but I'm also aware that people watching might be concerned about the treatment process if the worst happens. And this is always something that gets me, is that I've seen stats recently which have shown the reason why people aren't getting screenings and checks is because they're worried that they will have something wrong with them. But obviously, the secondary to that is if you do have something wrong with you, the key is to get it fixed as soon as you possibly can. So I know this, again, won't be relevant for everyone, but are you able to explain just a little bit about the potential treatment options that there are, just that people have awareness of that?
Yes. So with more and more treatments now being available for breast cancer, the actual discussions with any patient about treatment become more and more complicated. So traditionally, someone diagnosed with breast cancer would usually start with having some form of surgery. Everybody will have heard of lumpectomy. We tend to call it wide local excision, but it's essentially removing the lump with a bit of normal tissue around it. And about 70% of patients have a small enough tumour for that to be a safe operation to do. If the tumour arises in more than one place in the breast, which can sometimes happen, it's what we call multifocal breast cancer, or if the tumour is quite large compared to the size of the breast, or if it's right in the middle of the breast and involving the nipple, then those would be indication to have a mastectomy, where you attempt to remove all the breast tissue. And that can be combined with a breast reconstruction, either at the time or sometime in the future. So a lot of the initial discussions will be about surgery and which type of surgery is most suitable. There may be a choice for some patients, and we should discuss the pros and cons of the choices with patients. And then in addition to that, we would usually do some kind of biopsy on the lymph nodes to know whether we have to remove a number of lymph nodes, or it's really just to check whether the cells, the cancer cells, have spread to the lymph nodes or not, because that's the best test of whether there may be tumor cells elsewhere in the body. And if that's the case, then we would need to go on to overall treatments. So that the surgery deals with the local, it's the local part of the treatment, if you like. Then there's the more overall treatment, which can be hormone therapy or chemotherapy. And we use the results of the tests on the tumor to decide whether someone would benefit from chemotherapy or not.
Okay.
The majority of breast cancers have these hormone receptors in them, which means those patients will benefit from taking hormone treatment. And so it's a complicated process, and sometimes these treatments will be in a different order. But the treatments that are discussed with any one patient will be agreed by the multidisciplinary team and then presented to the patient as the treatment options.
Amazing. It sounds like the relationship that you have with your consultant is quite important in this process.
I think it's hugely important, yes.
Does a patient have options or choices within that, or are you kind of assigned a consultant and that's who you'll be working with throughout the treatment process?
Yes, it's quite complicated. You're looked after by the same multidisciplinary team, but you may see different members of that team at different outpatient appointments. When you have something like radiotherapy, for instance, you will be nominally under the care of a consultant, but again, you may see members of that consultant's team while you have that. So I think one of the things that is very difficult to do in the NHS is to provide that continuity of care where you see the same person every time. And that's really just due to the massive demand on resources.
Mm-hmm.
And whilst I appreciate that continuity of care is hugely important from a psychological point of view, it's just not always possible in the NHS.
Yeah, I think it's good to set people's expectation though as well. And at the end of the day, I'm sure they're the best people to handle all these cases. And on that note of kind of being stretched, and we all know that there's so much pressure in so many different ways. Just something that we talk about less now, but obviously the effect of the pandemic and the backlog, is that something that's still relevant? Because we heard the stats, I think last year when we had this conversation about the number of people expected to be undiagnosed with life-changing conditions potentially because they hadn't been checked through the pandemic. So are you just able to provide a quick update on kind of like where we're at now, and again whether we still need to continue to push people to really get those screenings when they need them?
Yeah. So if we look at diagnosis and treatment, sadly, since the end of lockdown, the waiting times both for initial cancer diagnosis and then for cancer treatment have just increased. So we tried to offer someone their first treatment for cancer within 2 months, 62 days of the urgent GP referral. But unfortunately, that's being missed in about 40% of cases.
Wow.
So there is huge pressure on the NHS for cancer diagnosis and treatment. It's not going to be resolved without additional resources and without a complete review of the way that we deal with cancer patients.
Sure.
That I think we've got a system that was failing before lockdown. And sadly, as a result of lockdown, it's on the edge of failing even more. And so we keep pushing for additional resource, but at the moment, and especially with cuts to public services being discussed openly at the moment by the government, it is a worrying time, I think, for cancer patients.
And on that point, I guess like there's once you've been diagnosed, there's a completely different treatment pathway. But Check4Cancer, obviously a key partner of ours because of the screening process and making sure people are diagnosed as early as possible. So in terms of breast cancer, you're able to explain how Check4Cancer could support people?
Yes, so if you develop breast cancer symptoms like we discussed earlier, the gold standard is that you come to a clinic, you're examined, and you have all the tests that you require performed at that first visit. And you know, that's the service we offer to your Vitality members. I think from a psychological perspective, that's really important. And as part of that, usually if during that first consultation you're suspicious that someone does actually have breast cancer, it's usually better to discuss it up front at that time. They've had all the tests done, and then you're just waiting for the biopsy result. And if you do it that way, when the patient comes back, they're expecting you to confirm what you thought, and then they're much more focused on the next part of the conversation, which is to discuss, well, what treatment are you going to offer me? When can I have my treatment? Where do I have to go for it? Whereas if it's presented as a complete surprise at that follow-up consultation, then the patient nearly always just shuts down, and they're worried and they're concerned, and they tend not to hear, you know, the rest of that message. Sure. So I think gold standard is to have all your tests at what we call a one-stop clinic. Unfortunately, I think it's something, again, that NHS services are able to provide less and less, because it does take additional resource, but it's clearly the best thing for patients with breast symptoms.
Okay, perfect. Thank you, Gordon. And we're going to bring Lisa in a little bit later, and she went through the treatment and the diagnosis process with breast cancer. So she's going to bring all of those things to life a little bit more. But at this stage, if we just move on to cervical cancer, because it's something that's been in the news a little bit more recently with some changes, which we'll discuss. But in terms of the first place to start, again, Gordon, just to raise the awareness for people, signs and symptoms and things that people should be looking out for.
Yeah. So the first thing to say about signs of cervical cancer are they're quite general, and they usually present when the cancer is at, you know, quite an advanced stage. And that's why we really support, you know, people getting vaccinated and screening, and we'll come back to that. That's why the real focus has to be on screening for cervical cancer. So the signs are painful intercourse, unusual vaginal bleeding, offensive discharge. Now, all of these could be due, you know, to a lot of different things. But those would be the main ones.
Okay, perfect. And in terms of, we'll cover this bit a little bit more now, I think, and the screening process has kind of changed in Wales, I understand, and there's potential that might change for the rest of the UK as well, in terms of the frequency at which women are encouraged to go and have their screening. So would you firstly be able to talk us through like the screening process and then that change that's happened as well, and why? I think because that's caused concern.
Yes, I will. So there are two strategies to prevent cervical cancer happening, and together they can pretty much eradicate cervical cancer. So the first thing is that we've been vaccinating girls aged 12 now against HPV, and some of those first girls that were vaccinated are now coming through to start cervical screening. So that's really good. And we're also now vaccinating young boys. So that's a really important part of the prevention strategy. The second part is cervical screening. And traditionally that has started at age 25. And initially it's been every 3 years. And then when you get to an older stage, it becomes every 5 years. Now, we know that NHS Wales has recently announced earlier this year that the 3-year interval would go up to 5 years for the younger women, and the 5-year interval would go up to 10 years for the older women. And that is predominantly due to the success of the vaccination program. So it means because nearly all young girls will have that vaccine, and because boys are vaccinated, that the screening doesn't need to happen so often, because the risk of cervical cancer happening is much less because of the vaccination program. Now, my understanding is from our clinical advisor that there is going to be a similar change to the intervals from NHS England. Just when it happens, I'm not sure. I think it's likely to be later this year or early next year. So I think that's coming. I think the important message is it's the combination of the vaccination program as well as regular screening that keeps the number of cervical cancers, you know, at a low at the lowest position. But again, not everybody accepts the invitation for screening.
Yeah, and that's one of the points that I was just going to ask that, Gordon, actually, about. I
Yeah,
mean, it's amazing to see that vaccination process is so effective. Again, would you be invited to go in and have that done? And is it optional? And if you
yeah,
choose not to have it done, does that mean that you should still have screenings more regularly and you shouldn't extend the amount of time that you wait?
yeah. I think, you know, at the moment, I think over age 35, about 1 in 4 women don't accept the invite to come for
Okay.
cervical screening. In the younger age group, it's about 1 in 3. You know, it's a big number, and so it is really important to attend. And if 30 to 40% of people don't attend, then we are still going to see cervical cancers diagnosed every year. If
Sure.
we had 100% acceptance of screening as well as vaccination, then we would hardly see any cervical cancer in
Wow.
this country. So it's we're doing the right things to eradicate it, but for a number of reasons, you know, some people just don't want to accept the screening
Sure.
invite.
Does requires people buying that understand that. And in terms of the screening process, what are you able to just show us kind of like what's involved, how it works, what people could
Yeah,
expect?
there are two ways. So if we look at the NHS first, the National Screening Programme, that still involves having a cervical smear, which would usually be done by a nurse. And what they do is that they test that sample to see if there's any HPV on the smear. If there is, they will then go on and look at the cells to see if those cells are normal or abnormal or potentially cancerous. And then those patients, if there are abnormal cells, they would be recalled. So that's quite a change. In the old days, the smear would be looked at, the cells would be looked at first. And then, but now we know that because we know HPV causes cervical cancer, they look for HPV first and then only
Okay.
look at the cells if they have to.
Interesting.
From in the private sector, we, like many other providers, are offering an at-home HPV test where women can do that swab themselves, and then if it is positive, then they would go forward and have further investigations.
Amazing. I think it's again, it probably puts people at rest a little bit because you hear the names of the screenings and stuff, and it makes you worry a little bit. But I guess actually, when you can do it at home and stuff, people who are doing it in their own homes, I think it makes it a little bit less stressful. Again, we have to come to this, like in the event of the worst case scenario and you are diagnosed, treatment process. Again, I appreciate that there isn't one for everyone, but do you have are you able to kind of explain a little bit about the treatment options or what people again could expect with that?
Yeah. So if someone is diagnosed as having abnormal cells in their smear, they would usually go forward. They would see a gynecologist and they would have what's called a colposcopy, and that's where the cervix is really carefully looked at and examined. And there are a number of ways that you can do that now. And for the majority of cases, the cells can be destroyed without major surgery taking place. And that's because you can pick up the changes quite early with regular smears before they get to an invasive cervical cancer. You can pick up the kind of very, very earliest changes. And so, and by regular examination, you can stop, you know, that progressing to a full-blown cervical cancer.
Sure.
If somebody does have a more advanced cervical cancer, then surgery would be required, and that would normally be a hysterectomy.
Okay, perfect. And that's, I think, what everyone associates the treatment with. But again, it's
Yes.
good to know that's not always the case. Gordon, final question before we bring Lisa out for a chat. Again, in terms of Check4Cancer and how you're able to support, are you able to share on that?
In terms of cervical cancer, yeah, I think
Yeah.
that there are a number of barriers, I think, to accepting that going to have a traditional smear test, and that can be for a number of reasons. You know, it can be different amongst different ethnic groups. Acceptance of any screening is less in urban rather than rural areas. It may be due to, you know, different traumas in the past. So I think being able to do an HPV test at home in the comfort of your own home when you want to do it without, you know, having a speculum examination and someone else take that, I think has been a huge step forward. And we know that the efficacy or the effectiveness of a woman doing the swab herself is just the same as a clinician doing the swab. So
Right.
I think that's been a major step forward, and it's now becoming more widely accepted. We've been doing it for 7 years now because there was good data very early on, and it's good to see that is becoming an option. And I know the NHS are doing some pilot studies on at-home testing to see whether that is something that could be introduced to the NHS screening programme.
Amazing. Yeah, that certainly sounds like a great option, and hopefully that more people would take up. Gordon, you're the most knowledgeable person I've ever met in my life, I think. Thank you for always sharing. At this stage, shall we bring out Lisa to have a chat about her experiences? Lisa, so good to see you again. How are you?
I'm good, thanks, Jamie. And thank you very much. Nice to see you again. And thank you for inviting me back and Vitality for all the support they've given me. And also a big shout out to Gordon and Check4Cancer. You guys have been fantastic and supportive with everything you do and all the great advice you give me once I got to know you last year as well. So thank you.
What a start, Lisa. And you and Gordon have two of the best accents I've ever heard. So I could listen to you all day long. Lisa, you were so kind as well last year to share with us kind of like your story and your treatment. I think this stage is important for people just to listen and understand, because again, like the perceptions or the, people's worries and fears, like you had all of those things come to you. So if you don't mind, and go into as much detail as you like, but would you be able to kind of start with what made you go for your initial checkup and then the kind of steps that happened after that point?
Yeah, sure. Thanks, Jamie. It actually started in lockdown. So I felt it was April 20, when was it, 21? I found a lump in my breast, everything fine, kind of didn't really heed it that much, to be quite honest. I did do checks ever so often, but I to be fair, I don't think I knew what my normal looked like before having a cycle and after having a cycle. So I found this random lump and I kind of thought, oh, it'll be fine, as you do. Well, some people do. And then I kind of persisted. It was there for days and days. And then after a while, I thought, maybe I need to take this a little bit more seriously. So the end of May, I contacted the GPs, but unfortunately, that's when lockdown had just literally kicked in. So it was very early on knowing what to do. So they wanted to diagnose me of the lump over Zoom, which wasn't ideal. But luckily, I got eventually in touch with an actual doctor, and they said, no, come in straight away. We want to have a check what's going on. I seen a GP. They weren't quite sure, but they said, we don't know the process, but we're going to refer you anyhow. We think it may be cancer, it may be cyst, but we're not 100% sure. So they referred me then on to the breast cancer clinics. And they were a little bit behind because of all the pandemic was something completely new. They didn't know how to handle really cases that well, I guess, from an overall NHS perspective. So normally I think it's about 2 weeks once you get referred, you get a letter in 2 weeks. Mine was a few weeks later, so it was later on in June that I got that letter. But when I went in to see them, they said, come by yourself, which was always hard. So my partner dropped me off in the car park. I quite frankly went in naively thinking, oh, it's just a cyst. Yeah, I think I had one before, and etc. Went in, fantastic treatment from the NHS, from the breast clinic team. They did some mammograms. The mammogram, unfortunately, didn't spot they did 11 mammograms. It didn't find the cancer, but they could feel it. So then they did an ultrasound. They could see it on the ultrasound. They showed me that little lump on the ultrasound. And then they did some biopsies and put some titanium into the lump so they can measure from the next time they see and the next time they scan how much it's grown. And at that time, they give me a rating. Going back to what you said, Gordon, and I think it is vital at that first time that you're told already with all those fantastic scans I had and checks was, we think you've got a good chance, Lisa, here. I think they give me between 0 and 5, and mine was a 4 to say, we think, Lisa, you've got cancer, but we're not 100% sure. There's still that little glink that you may have. It may be just false misreadings, and we'll wait for the biopsy to come back, but just prepare yourself. So actually, when I heard that you're by yourself, you've got the surgeon who was fantastic. And she actually did surgery on me later on, and another surgeon as well. And the nurse is with you, and they're caring for you because there was no one else. You're in there by yourself. So I kind of thought in my heart, I thought, oh, okay, they know what they're doing. They see this every day. I think they know what they're talking about when they give me that score. And so I went out of there at the same time with a little glimmer of hope, thinking, well, actually, they haven't seen the biopsy, so maybe I'll just wait for the biopsy. And then actually I went to see a friend straight away. I didn't tell my partner. He didn't know. I went to see a friend and I said to my friend, I think I might have cancer. And she said, have you? And we went through, she said, oh, kind of similar to me, I think. Well, let's wait till the biopsy come back. And I kind of talked myself into, let's wait for the biopsy. I genuinely did say, let's wait for the biopsy every day. There's no 100% proof. And that was the proof. And then a follow-up from that, a few weeks later, I got a phone call that said, Lisa, we've got the results. Can you come in again to see us? And I also got a letter a few days later, but I'd seen them. I went in to see the consultant, the surgeon that was going to ultimately treat me as well. And they basically said, unfortunately, Lisa, you've got high-grade invasive ductal cancer. And it's grown a little bit from what we've seen. There were the follow-up scans, and basically they gave me some options of the treatments. So one of them was a full mastectomy, which at that stage I was literally in shock, which is kind of naive really, because I think I knew that about 4 weeks before when they kind of said it was a good high chance. It was a partial mastectomy, as they call it, so as well. Which is kind of lumpectomy and a little bit more on the pull, as some of the muscles to build it as well. And they were the options, and then they went through what possible options could happen depending on the outcome of those first operations. And when they check out your lymph nodes, if it spreads, there's a possibility you might have chemotherapy, that you might have radiotherapy. So to be fair, they're very transparent. They set you up to say you might have these things, but nothing is set in stone until they see the next lot of scans or results or surgeries. So that was, that was very devastating, because straight away I have 2 young kids under 10, and the first thing I thought of was them. And the first thing you think of is negativity, is God, this is life-changing. Will I die from that? I thought that straight away. I admit that to everyone that I speak to, because that's the first thing that's in your head. Cancer is that association of negativity, isn't it? We always hear more the bad press than actually all the wonderful successes there is, and the fantastic science and cures or preventative medicine there is with cancers. And then I went from there to a few weeks later, very quickly, I had my first round of surgery, and they took out, as you said, Gordon, they took out those parts of the cancer that was in there, the tumors. And then they also said, Lisa, we've checked your lymph nodes. It's spread to some of your lymph nodes, so we'll have another operation in another few weeks' time. We'll also do a biopsy in the meantime to check, but they confirmed that my lymph nodes had cancer in it. So a few weeks later, I came back in the following September. This went all between kind of July to September. So it's actually very quick. So I went in the June, they kind of said I may have it. By September, I was on my second operation, and I had my lymph nodes removed from under my arm. And then by then they had already said, Lisa, we recommend you having chemotherapy. We recommend you having these many cycles. This is the kind of therapy you have. We're recommending you have probably radiotherapy after that. So then I went straight into, pretty much a month later, the end of October, actually about now, it was literally now about 2 years ago, I went into chemotherapy, a treatment called, don't ask me to pronounce it, but it's called FECT, F-E-C-T. And then after that, I also had 6 rounds of that. I also then went for another 6 rounds of another one called Paxitexel. So these are the chemical treatments. And I found chemo really, I was very fit and healthy, but I found that flatlined me completely. I was not in a good shape. My hair is back now. It's fantastic. Oh, my hair. It's the first thing you think of, isn't it, with chemo? You lose your hair on your head, but you don't realize all the other symptoms. You lose your hair on all your body, weird things, and all your eyelashes. I feel sick a lot. I was nauseous a lot. I had absolute massive fatigue, unbelievable fatigue. But I knew every week I had brilliant treatment with the chemo nurses. It was a very isolating journey because no one's allowed in with you. My husband would drop me off in the car park, my partner, and you're in there for several hours with all them, the oncology team and the chemo nurses, and the volunteers from the various charities beside you and supporting you. but you're in there by yourself ultimately with other cancer patients, and that's quite daunting. You know, there's a few you in a room that's all going through chemo, and you have 5 minutes chat, but you're all in a mask. It was a really, really tough time. So you've got no one to support you. Everything is extra. You don't know what to do. You have to ask, can you do things? Because everything is quite isolated with the whole pandemic and the COVID restrictions. So it was kind of alien to everyone, to be fair, that was doing it. But the treatment was fantastic. The support, without question. I brought in chocolates every week and booze to the chemo nurses. And the oncology team, they were absolute saviors to me. And we had good fun. We built up a great rapport over the weeks because it went on for months, right? So you know them. I know more about their family. They know more about my family. It really is a great partnership and fantastic treatment. And then after the chemo finished in the that was 21. Then I had the radiotherapy for 25 blasts of that, for want of a better word. And I found radiotherapy really easy. Everyone said it'd be really hard, but I suppose after chemo, when I was completely flatlined, for want of a better word, the radiotherapy was a breeze. I was feeling I was coming out the other end there. But I know a lot of women and men find radiotherapy really tough. So I was very lucky in that, to be fair. Chemo just hit me harder. And the support was fantastic, and the company I worked for was fantastic team. My managers, fantastic support from them, and I think that is vital, that you've got really good, if you're working, you've got some great support from the teams and the companies you're working for, that understanding, and also from your friends and family. I got great support, and it's a shock. So I think sometimes they don't tell you the pros and cons of cancer is the friends that you never knew you had, that are their acquaintances. They're some of my best friends now, and the friends that I thought that was really, really close to me just didn't know what to say, and I ended up comforting them more. And then I thought, I need to keep my strength for me and for my family and for my kids. So it's a real life changer, not just physically but psychologically, and it changes you in every way. I'm not the same person I was before cancer. I know that sounds, I'm sure, Gordon, you've heard that loads of times before. Physically you change, everything changes, not just how you look, but emotionally, mentally, personality, everything's changed. You don't take things for granted anymore. You seize the day, but also you know who's your importance, who was those friends and those people, those strangers that come up to you with some support that you don't know who they are in a car park, and the amazing good that come out of it, as well as obviously the negatives. But I have to see there's more good. And I'm here because of the fantastic work that Gordon and his team has done, and the NHS, and the team that I work with locally, who is absolutely fantastic. And I followed, I won't lie, I followed and did loads of research myself, but I followed their procedure religiously. I didn't deviate. There was times I was thinking, is this the right thing to do? I did quiver. Should I go down a natural remedy route? I did look at that, because the chemo I was finding it really, really, really hard physically. I was in bed a lot. I was tired. I was sleeping for 18 hours a day. And when I was awake, I was sick a lot. I didn't eat. I lost 2 stone. And I did think, is this really worth it? And those strangers I met on forums and people I'd spoken to in chemo, and they said, no, keep at it. It's the worst. This is the lowest you're ever going to get. Keep at it. And I did. And those strangers and those people that I met was the best thing. So, in adversity, is listen to those little words. Don't heed the things that's in your head. Should I look for alternatives? And there might be success for some people, but I continued that treatment. I listened to the oncologist, and I listened to a wider brain, a lot of people as well, and read loads of articles and research, and bought endless books on cancer. I'm very lucky. I followed the rules, and on that basis, and fantastic support from everyone.
Lisa, I think it's now, like you say, 2 years later. I think the way that you talk is amazing. Like, you've got a real good balance of, you're super positive, but you also say some things which are entirely realistic, and you're not like, everything is your honest and real experience. And I could listen to you all day, and you look amazing. And I think that you're helping so many people now, and we really do appreciate that. So thank you so much for being part of this again. Whatever I say, or to be honest, Gordon, I hope this isn't offensive to you, whatever we say, people listening to you is probably going to be the best part of this session. So
I completely agree. I think you're a great ambassador, Lisa, and with a very realistic expectation, but a very positive outcome, which is great.
Yeah, thank you, Gordon. And that positivity is really, it doesn't work for everyone, I know, but you do have to look for those lights and keep focusing on your journey and not listen to the other people, the negativity around you, and just listen to the experts, quite frankly, as well. So thank you guys for giving me this opportunity, and absolutely, if anyone wants questions or any advice or anything I can support with, by all means, the more awareness we can spread about this, the better.
The privilege is ours,
Thank
Lisa.
you.
Thank you so much, and we'll speak to you soon. Have a great day.
Bye-bye.
Okay, thanks.
Gordon, I mean, I don't know what more we can say. I think Lisa spoke so perfectly, and the realism there was something that got me. The first thought when you get diagnosed is, this might be the end for me. Is that something that you've experienced as well?
Oh, I think I'm sure every patient will go through that, and I think she described really an excellent diagnostic and treatment pathway. I know it was delayed at the beginning because of the pandemic. I know she had to go on her own a lot for some of her treatments, and that's hard because we always recommend that you come with someone, that someone brings you and helps you. And I think the only thing I'd like to bring out to add to what she said is that Zoom meetings are not great for diagnosing cancer. So if any of the listeners are worried that they have a particular cancer, insist on a face-to-face appointment with your GP. They have to do that, and you cannot diagnose cancer on the phone or on a video conference.
Amazing. I can see Lisa behind the scenes. She's definitely agreeing with that. So make sure that you know your rights and do that. Gordon, we're going to wrap up today's session, which has been amazing. I get to do the most incredible things as part of this job, but this is always the most important and impactful session that I always find. So we're just going to cover a few questions, if that's okay, to wrap up. One of the most common ones that we've had is around people who are maybe going through menopause as well. So the key question that we have had quite a few times is, does HRT cause breast cancer? Now, I don't know where that's come from. Maybe that you can share a little bit about why people might think that, and then if you are able, if there is an answer to that question as well.
There's good published evidence to show that it causes a small increase in breast cancer risk while you're taking it, especially in HRT that combines estrogen with progestogen. But then when you stop the HRT, then it returns to your risk returns to normal. But the important thing is there are lots of benefits from HRT. And so that's why it's important that if someone thinking of starting it, they have a discussion either with their GP or a gynecologist about all the benefits and all the risks. And I certainly would not be saying that, people mustn't take HRT. I think a good discussion of the pros and cons, small risk, but returns to normal quite quickly when you stop it.
Amazing. Perfect. Another question someone has said here, I'm nearing 60 and was told that my next breast cancer screening will be my last. Does the percentage likelihood significantly decrease at 60? I think we covered this a little bit earlier on, but did you also clarify that?
I think the peak kind of incidence of breast cancer is from 65 to 69. And then NHS breast screening program stops at 70. So I would expect that the person that asked that question to be eligible for screening up to the age of 70. I can't think of any reason why it would stop at age 60.
Okay, perfect. I think there's a few questions actually that are similar to that. And this final one that we'll end on is specific to cervical cancer, but I'm sure there's other people in this situation, so I'd probably apply it to all cancers. So someone said here, what do I do if my pap test isn't due for another year, but I'm worried something is wrong, but also my GP doesn't think there's anything to worry about? So they've not reached the age, they feel something's not quite right, but the GP doesn't see those signs and symptoms. So I think it's probably covers the board of all cancers, really.
Yeah. So I think if it's a difficult one, because the 3-yearly screening at the moment, or 5-yearly, depending on your age group in the NHS, is quite regimented, and they'll not do extra tests in between. So one thing that member could do is to do an at-home HPV test, and if it's positive, then the options are, if the GP will not act on that, is probably to get a private smear done or a private examination done. I think those would be the options.
Amazing. And Gordon, last thing to wrap up, anyone wanting to find out more about Check4Cancer and the services that you offer, is there someone that you direct them?
Yeah, we've got a very educational website, which is check4cancer.com, check4cancer.com, and there's lots of information on there, and there's a lot of information in the blog, which is our reaction to a lot of the cancer stories that come out, and I think that's a very good way to do it. I'm also quite active on LinkedIn, and people can follow my reaction to lots of the cancer stories that come out. Twitter less so. I think LinkedIn is much more educational and much more sensible, and I quite like that as a forum for trying to raise education about all types of cancer.
Amazing. I follow you, Gordon. I think people definitely should check that out. And honestly, like, if anyone's watching this, please do watch this, obviously on behalf of yourself, but these sessions, like, we have the potential here to help so many people in such a serious way. So please do forward these videos on wherever you're watching. If you're on YouTube or wherever you are, make sure you share the message, because like I say, if we help one person from this in the tiniest way, that is the biggest return that we'll ever get. So Gordon, as always, thank you so much for your time and your knowledge. And I think the way that you explain things just puts you at comfort. So you're just perfect for these sessions, and we're so grateful to work with you and Check4Cancer.
Yeah, always like to do these, Jamie. So yeah, thanks for asking.
Thank you. And again, to Lisa for being part of this. It's been amazing to work with you again. And everyone watching, please do share far and wide, like I say, and hopefully we'll see you at another one of our sessions too soon. But in the meantime, take care and have a great day.